For Chapter 6, we'll be looking at bone tissue. We're looking at different things that will comprise bone. We'll talk about the undifferentiated tissue that bone will be derived from. We'll talk about different kinds of forces that will act upon bone, and I'll show you some disease processes as well as to what things can run amok concerning bone tissue. This will be the first chapter. We'll take a closer look into looking at x-rays, so I'll give you a crash course on what we're looking at and also what body parts and how to differentiate one particular tissue from another. Bone tissue, or the skeletal system, will have 6 different functions. One, it will provide support for tendons and ligaments and helps us maintain certain types of postures. It will protect the internal organs. This shows just the brain and heart, but also can include the gastrointestinal organs, and as well as for the female side of the species will protect their organs, whereas the male, it provides little to no protection, if at all. It also assists in body movements in conjunction with the muscles themselves. It is an excellent store for calcium and phosphorus. It will produce red blood cells in homeopoiesis as well as white blood cells, and also, of course, will store triglycerides and adipose cells of the yellow marrow. When we talk about the structure of bone, bone can be found in different types of shapes. The one that's most familiar to most of us is known as the long bone. The other types of bones we'll pick up as we get into the split of the axial skeleton and the appendicular skeleton, but the typical bone that most people are most familiar with is the long bone. The long bone is going to have a bone shaft known as diaphysis. It'll have 2 ends, which will be called the epiphyses. These will form joints with the either the proximal or distal bones themselves. You have 2 metaphyses. Is going to be found between the diaphysis and the epiphysis. You're going to find articular cartilage that will be at the end of each epiphysis, as well as a periosteum, which will be the connective tissue surrounding the diaphysis themselves. The periosteum is also going to be very highly innervated as well. So when there is any type of fracture, the pain doesn't come from the bone tissue itself, but rather from the periosteum. When it gets torn, it can become very, very painful. And then found within the diaphysis, you'll find the medullary cavity. There's a hollow space found within the diaphysis where the bone marrow will be found. And finally, you have the inner lining, which is known as the endosteum, which is going to be a thin membrane that's going to line the medullary cavity. So again, to remember, periosteum is the outermost covering of the diaphysis of the bone, and the endosteum will be found in the medullary cavity, a very thin membrane there. Here's a quick picture of a normal long bone here. So again, you find the diaphysis, the shaft in the middle there. On both ends, you'll find articular cartilage. This is actually humerus. It's actually the right humerus of the appendicular skeleton. When you move a little further down from the articular cartilage of the head of the humerus, you go further distal, you'll find the proximal epiphysis, and you'll see what's called the epiphyseal line. This is known as the growth plate. We'll talk about that a little bit later on. Next, you have the metaphysis, then the diaphysis of the center of the bone. Found within there, you'll find the medullary cavity for yellow bone marrow. You'll find it be nutrient dense with nutrient artery. You find the periosteum listed on the outside portion of the diaphysis there, the outermost covering, and you'll find the endosteum found within the medullary cavity. That's the lining in that particular area there. And then followed distally, you'll find the metaphysis on the distal side, as well as the distal epiphysis, as well as the articular cartilage, which will line the distal end of the humerus bone. We find 4 different types of cells found in bone. We find first the osteoprogenitor cells. These are bone stem cells that will differentiate into other types of cells. You find osteoblasts, which will actually build the bone and excrete the matrix. You'll find osteocytes, which are the mature bone cells once the bone stops growing. And finally, you find osteoclasts. These will remodel bones and actually cause them to break down into calcium and phosphorus. So the best way to remember these 2, osteoblasts will build, osteoclasts will carve. Very simply, there is a race back and forth between osteoblasts and osteoclasts as the bones are constantly being made, or bone tissue is constantly being made, and also recycled at the same time. This helps remodel bones due to different types of forces being placed upon it, which we'll talk about in just a little bit. And here we see the different lines of different types of cells found in bone. First, we have the osteoprogenitor cell. This will develop into an osteoblast. The osteoblast will actively start to secrete the bone extracellular matrix. Once the bone is mature, you find the osteoblast will differentiate into osteocytes. These will help maintain bone tissue. For osteoclasts are actually macrophages. These actually work to break down by secreting enzymes in extracellular matrix. They're signified by a ruffled border, almost the minnow-pseudopods that we had talked about before. These finger-like projections will help destroy or at least release the enzymes to break down the bone matrix as much as possible to help release calcium and or phosphorus at the same time. Found within the bone, the structure of the bone, we find two different parts. We find compact bone, which you'll find mostly at the periphery of the bone itself. It's very good for providing protection and support. And found within, you find spongy bone, which is both lightweight and also provides tissue support, in this case for red and yellow bone marrow. So our first question of the chapter is spongy versus compact. So basically we're looking at the advantage of having spongy bone in a bone itself and not solid compact bone all throughout. So very simply, when we look at a bone, especially when we look at the bone in lab, you're going to find a very dry, very brittle bone. However, we don't have that in the actual human body. When the bone is in the body, it's bathed in different types of fluids and blood. It's actually somewhat bendable, not completely bendable, but somewhat. So if you were to have a solid compact bone, very simply with any kind of force, either an impact force or any kind of force that's perpendicular to the diaphysis of the bone, a compact bone actually will fracture due to its inability to bend and absorb the impact of the force. Whereas if we have spongy bone, it allows a little bit of bending, so it allows the compact bone to kind of bend and twist slightly and able to dissipate that force as best possible. Naturally, if you had something that had too much force, it'll break the bone no matter what. But having that spongy bone actually allows a little bit more of a resistance to impact forces in particular. But also having spongy bone found throughout the bone itself actually makes it more lightweight and actually allows it to be less stress on the muscles and of course less stress on the heart as we try and move the body back and forth. Those of you who know people that have an extraordinary amount of weight on the body, it puts a lot of pressure on the bone itself. You don't want to add more weight just by having compact bone all throughout. We will look at different types of disease processes where the compact bone a lot of times does overgrow. You see that obviously these people have very distinct features and also have very weak muscles to boot. Now, bone tissue in particular is actually fairly well vascularized. We have different types of arteries that will enter through different parts of the long bone. We have periosteal arteries, which will enter the diaphysis through the Volkmann's canals. These will actually supply the actual periosteum, the outer covering of the bone. These are going to be accompanied by the periosteal veins. For the actual diaphysis, it'll have both a nutrient artery and nutrient vein. They'll enter through the nutrient foramen. The metaphyses and also the epiphyses will have their own distinct arteries and veins correlate that particular area. In the diagram here, you can see the shin bone, and we're looking at the most proximal portion of the shin bone. You see in the epiphyseal area, you see the articular cartilage up at the most proximal area there. We know this is tibia because it has two twin peaks right up top there, which we'll get into more so in the appendicular portion of the skeletal chapters. But it has its own epiphyseal artery and epiphyseal vein. You see that the epiphysis and the metaphysis are going to be separated by the epiphyseal line. This is a fully matured growth plate. Once we see the epiphyseal line, we know that the bone is fully mature. It will not grow any longer. At the metaphysis, you see both the metaphyseal artery and the metaphyseal vein. You also see in the diaphysis, you'll see the medullary cavity. You'll find just going through or just through the perforation of the periosteum, you see both the periosteal artery and the periosteal vein. And you see the actual nutrient artery and nutrient vein traveling through the nutrient foramen, which takes care of the diaphysis and the medullary cavity. One thing that's not shown here is the different types of nerve innervation. You very simply have quite a bit of sensory neurons found all throughout the periosteum that detect any kind of bending, twisting, or tearing of the periosteum, which therefore usually means like a fracture within the bone too. This is why oftentimes any kind of break or any kind of twist of the bone can be very painful. This is why deep bone bruises can be very painful as well, because of the highly innervated area of the periosteum itself. So I mentioned the epiphyseal plate. The epiphyseal plate is going to lay the groundwork for long bones to grow. And we're going to have two epiphyseal plates, one at the proximal end and one at the distal end. The problem we're into is if there's any kind of fracture at the epiphyseal plate during your developmental years, and this goes all the way up to age 24 is when you officially stop growing. This can disrupt or even halt bone growth, creating posture and weight problems as the person develops. So if you can imagine if a young, let's say if a adolescent gets hurt through sports or falls down steps or some kind of gymnastic event, and they fracture the epiphyseal plate, that particular portion of the long bone will not grow any longer. If it's a problem with the lower extremity, they can show a severe difference from one side to the other as far as leg length goes. which can have a lot of different problems with biomechanics as far as walking, making running very difficult. It's a little less haphazard when you deal with the upper extremity, although it can cause issues there as well, especially if it's on the dominant arm. So here we get our first look at an x-ray, and we're looking at two wrists, in this case of a gymnast, with what's called a physial injury. In this case, this particular person had what's called a repetitive stress injury, which means that there was no one single event that caused the kind of injury, and we're looking at fractures very simply here. In this case, it's repetitive stress of constantly laying on the hands or going off the vault or just simply any kind of normal fall repeatedly over and over again. And a lot of times this won't have anything other than it's just very sore and tender areas where the fracture occurs. In this case, if you look at both wrists here, and very simply you see two long bones, one pair on the left side, one pair on the right side. If you notice, there's going to be a darker line at the very distal end of both wrists. We're looking at the ulna and radius here. If you look, there's actually two lines found on the radial end, and that'll be the area of the thicker portion found just below the thumb. In this case, looking at the x-ray, is the two medial bones that are going to have the stress injuries more apparent. You can kind of see a little bit on the ulna too. It's more apparent on the radial bones at the distal end. So very simply, what you're looking at, looking at x-ray, we have what's called radiopacity. So very simply, most of your soft tissues or water will allow x-rays to pass through an x-ray and will actually hit the film just after and cause a black image. Is when those x-rays get absorbed by bone, in particular compact bone, it shows up more as a white image on the x-ray here. So we're able to differentiate both the joint cartilage itself, which shows up more as a gray or a black, versus the actual bone itself. This is the way we can detect different types of fractures, in this case, in this particular x-ray. So again, at the distal end of both radius and also distant end of both the ulna, you're going to notice fractures on both of the epiphyseal plates. So we talk about fractures briefly. Let's talk about bone formation. We have two different types of bone formation, what's known as ossification or osteogenesis. This is the process known as bone formation. We find this happens in four different types of situations. Number one, during embryological and fetal development. Naturally, it starts off with a cartilage framework or mesenchyme and eventually starts to ossify. We also find this when bones grow before adulthood, when bones remodel. So when bones remodel, that very simply means if you constantly put a stress on a bone, the bone will start laying down more tissue to deal with the stress. And we'll talk about that in a little in depth in a couple slides later on. And finally, we also see bones start to form when fractures heal. We'll go through those particular steps in a few moments as well. So ossification can take place in two forms, either intramembranous or endochondral. Intramembranous we find mostly in flat bones where mesenchyme or the connective tissue membrane will be replaced by bone. In intramembranous ossification, we're going to find this occurs mostly in the flat bones of the skull, so in facial bones and also the medial end of the clavicle. And that's the important thing to remember. It's the medial end of the clavicle, which is also known as your collarbone. So let's look at the stages for intramembranous ossification. Very simply, in your flat bones, you'll find development what's called an ossification center. So very simply, the mesenchyme will start to differentiate from the osteoprogenitor cells into osteoblasts. This will already have a collagen framework to work with. The osteoblasts will start secreting the matrix and start to harden that particular area. You start going to the next stage known as calcification. So the calcium, phosphorus, magnesium are deposited into the external matrix, start to harden. As the osteoblasts start to form little lacunae, very similar to the chondroblasts we found in cartilage. The chondroblasts we found, or chondrocytes found in lacunae, you find the same thing also in bone. Once the osteoblasts are done secreting, they'll start to grow finger-like projections to the next adjacent osteocyte through these little mini canals called canaliculi, or canaliculus for the singular. So as you can see, you start having a calcified bone extracellular matrix that starts at the center of the ossification center and starts to grow towards the periphery. So you can see in stage number 3, we're basically starting from the inside, working our way out. It starts to form the spongy bone, or the trabeculae, to form the framework for the bone marrow. And finally, in the last stage, you have, once you get past the spongy bone, you start to develop compact bone, and finally the periosteum at the periphery of the mesenchyme starts to harden and form the connective tissue-like covering around the flat bone itself. Now, the other type of ossification that we see, this is more specifically for long bone. We see what's known as endochondral ossification. So just looking at the word, obviously it means that it's going to be a cartilage framework. Hyaline cartilage in this sense is going to be eventually calcified by osteoblasts as we develop as an embryo and later on into the fetus. So in stage 1, you can see the outerwork markings of a diaphysis and both the proximal and distal epiphysis. The leading edge is going to be perichondrium of the entire hyaline cartilage framework. Once we start to have calcification of the extracellular matrix right in the medullary area of the diaphysis, you start to see some the beginning markings of the periosteum just along the diaphysis on both sides, and you find a leading edge of uncalcified extracellular matrix there. By stage 3, you start to have what's known as a primary ossification center. You have the nutrient artery that's going to be feeding you nutrients and taking away waste, and you start developing the spongy bone, very similar to the intramembranous ossification. Next, you have development of the medullary cavity, the bone breakdown of the osteoclasts. As you remember, osteoclasts will carve to start opening up the actual medullary cavity. And as that starts to happen, you start having a leading edge of the calcified extracellular matrix start moving towards both the proximal and the distal end. And you finally see the leading edge on top of that, the uncalcified extracellular matrix, still cartilage at that point. Now, in stage 5, you start having what's known as a secondary ossification center that's going to work into the epiphysis. It's going to have its own epiphyseal artery and vein. And you notice that the two different ossification centers are going to have a bed of cartilage in between them. This little bed here is going to allow, first off, the diaphysis to grow in both directions from the proximal and distal end, and also allow the cap at the secondary ossification center for the epiphysis to grow at its own rate. Very soon we're going to see the formation of the articular cartilage and the epiphyseal plate in stage number 6, where this will take over for the perichondrium. You're going to find the epiphyseal plate will be the leading edge of new bone as it goes through both the proximal and distal end until it will finally fuse or catch up to the epiphysis in particular. Finally, look at the last image there in the lower hand corner. So this shows you both the areas where you find calcified bone and also uncalcified bone. This is a 12-week fetus. You won't get full calcification in some bones until the baby is born, especially along the ribs, and you get full ossification by the time you're 24, give or take. Here we're looking at an expanded version of the epiphyseal plate at the distal end of the femur. There's an x-ray up top there of a 3-year-old. Very simply, you're looking at the distal end of the femur. You see the end of the ossification is somewhat of a bright white line there. That's going to be fresh bone. And the black line there is the epiphyseal plate, which we know is not fully ossified, so therefore it is cartilage. Now, since this part of the femur is growing from the superior down to the inferior, we're going to look at the leading edge of the epiphyseal plate. So we're going to look down at the bottom zone here, known as the zone of resting cartilage. The zone of resting cartilage is simply there to help attach the epiphysis to the epiphyseal plate once the bone is done growing. Next zone up is the zone of proliferating cartilage. These are active chondrocytes laying down more and more matrix, more and more framework for the eventual ossification. Next, in the zone of hypertrophic cartilage, this will be mature chondrocytes. And next up, you'll find the zone of calcified cartilage. This is where the chondrocytes will die off and then be fully ossified by the osteoblasts that are screening more of the bony portion of the matrix, in this case calcium and phosphorus. So of course, with any kind of process we have in the body, when things go right, they go well. But unfortunately, sometimes things do not go right. So occasionally we'll get some abnormal variants or congenital anomalies, or occasionally we'll have something that actually may be very detrimental to the individual. So in endochondral ossification, sometimes it happens too little, sometimes it happens too much. So congenital anomaly, it will be a normal variant where cartilage does not completely ossify, where ligaments or cartilage ossifies when it shouldn't. So in this case, especially in my kind of practice, I see what's called a posterior ponticus. This was known as an atlas ossification of the atlanto-occipital membrane. So for those of you who are not familiar with where the atlas is, very simply, it's the top vertebra that your skull will rest upon. It's somewhat of a small vertebra, but there's a lot of ligamentous and a lot of tendon attachments there. There's a lot of different types of arteries, veins, and nerves that will pass through the area as well. So it's very important to make sure that there is just enough space for everything so things can move properly. Occasionally, though, if there's ossification of this particular membrane, which is also known as a ligament, this holds the vertebral artery and vein in a very particular position. However, With the ossification of that particular membrane, it occasionally can become jagged, and of course any kind of movement of the neck could actually tear either the artery or the vein, and of course that can be life-threatening in particular. And I'll show you a quick picture of that in just a little bit. Another type of endochondral ossification error will be spina bifida occulta. So spina bifida very simply is the lack of effusion of what's called lamina, which are two little portions. Remember we talked about the vertebral prominence, that little bump we find on the back of our neck. So very simply, on either side of the vertebra, it'll fuse together, left and right, to form that little bony protrusion. Usually we see spina bifida occulta more so in the lumbar spine, and a lot of times what winds up happening is it's occulted because it's hidden, which means it's not really detrimental. But if we were to do an x-ray, we would see that there would not be complete fusion, so it wouldn't be completely white on an x-ray. Now the next step up though, with spina bifida cystica, unfortunately what winds up happening, there is even a minimal amount of cartilage there, so what happens is the spinal cord, on the OSS card, it should say cord, and the meninges start to protrude, producing what's called a meningocele or a myomeningocele. Usually they can detect this in the womb. Unfortunately, it does require surgical intervention. It can be fatal, especially if the baby is born and your nervous system is exposed to the outside environment. That can cause a very, very high risk infection and, of course, be fatal to the infant. So here's another x-ray. First, we're looking on the left side. This is known as a lateral cervical x-ray. This takes a look at the cervical spine. So just a quick glance here, we can obviously see the teeth. So we know that's going to be the anterior portion. The posterior portion, you can see the little bump right on the outer edge of the skull there. That's your EOP we talked about in the first lab. So very similar, looking at different vertebra. And your atlas will be the first vertebra found underneath the skull. So we're looking at about 2 vertebrae up from the edge of the teeth. So you see in the anterior portion, there's a little knob and there's a little projection that points backward in the posterior. So very simply, on the flipped x-ray on the right-hand side here, you can see a little, almost form a little bit of a hole there. So that outer portion there normally is not ossified. In this case, the iliano-occipital membrane is going to be ossified. Your vertebral artery will pass through there. Normally, the posterior ponticus doesn't cause much of an issue, but if the area is somewhat jagged, it can tear in the vertebral artery and, of course, cause the possibility of a stroke or sometimes worse. On the left, we have spina bifida occulta. So again, normally this is hidden, where it usually doesn't cause any major kind of problem, where usually it just simply means that it's not fully ossified as bone, but there is cartilage filling in that space, so it's not an open, empty space. So looking at this on the left here, this was known as an A to P, or anterior to posterior lumbopelvic x-ray. So very simply, we're looking right around the waistline. You have 2 crests, your iliac crest on either side there. So if you look, there's definitely there's blocks that they stack up in lumbar spine. These are your vertebrae. So normally you would see a little line, little white line that'll pass through what's known as L1, 2, and L3. L4 and L5, you can see almost like 2 little projections kind of miss each other right around the waistline. That's what we know as a spina bifida occulta. A lot of times what the body may do is it may lay down more hair. In this case, it was known as a fawn's beard to help protect the area. Basically, the body knows there's not fully ossification center there. So lay down, in this case, hair to help kind of protect the area. Even though it may be somewhat minimal, it's still better protection nonetheless. Unfortunately, though, we do get spina bifida cystica, which we see on the right-hand side. I'll show you better pictures of this in the next chapter. In this case, it shows a representation of the meningocele or myomeningocele, where the spinal cord and also the meninges will start to protrude through not only the spinal canal, but also through the hypodermis, the dermis, and the epidermis. And as I mentioned before, they'll do some kind of surgical intervention, sometimes in utero, to fix this before the baby's born. Although, unfortunately, it does mean some kind of developmental problems or some kind of defects in the lower extremities. So for endochondral ossification, we've shown how a long bone can grow both from the proximal and distal ends. But also we have to talk about how bone actually thickens, in this case, the cortical bone. So very simply, you're going to have influential processes between osteoblasts and osteoclasts. As you remember before, osteoblasts will build, osteoclasts will carve. So very simply, we want to make sure that we keep only a certain portion of compact bone on the actual long bone itself. You don't want too much compact bone, because the bone can become too heavy and actually become too brittle in some instances, depending on the force being applied to the bone, especially if it's perpendicular to the diaphysis. But what simply winds up happening is the periosteum will have a periosteal blood vessel. It will form almost a perforating canal, and then what happens is the periosteum will start to fold in upon itself and create a tunnel for the periosteal artery. Very soon what ends up happening is this will start to feed all the osteocytes around the particular area. It'll complete the actual folding and create the tunnel or an endosteum for that particular area. This will cause concentric rings of osteocytes all around that particular nutrient artery. This is going to form what's known as an osteon. An osteon, very simply, it will be the nutrient artery as well as all the concentric rings of canaliculi, where the extended arms between the osteocytes and lacunae we found around the nutrient artery in that particular ring, known as an osteon. It's the functional unit of the actual bone itself, especially compact bone. These osteons will normally run parallel to the diaphysis itself. It will not run perpendicular because that is where the inherent strength will be with diaphysis, where the osteons will all run parallel to the shaft of the diaphysis. Now, in the bone tissue chapter, I feel like this is always a great question to kind of get us into different types of forces that will impose upon the formation of bone tissue. So in this case, we're talking about the physiological changes of bone tissue while an astronaut is in space. Fortunately for us, we had an astronaut by the name of Scott Kelly, who was a twin of also astronaut Mark Kelly, who spent over 300 days, I think 346 days, at the International Space Station between 2015 and 2016. During this time, they monitored Scott Kelly's physiology while he was up there, looking at different aspects and comparing that to Mark while he was down on Earth. So some of the things you can think about with bone tissue in particular. Now, bone tissue is dependent on gravity. You need some type of force being put on bone up to a certain point to allow the bone to grow. So one of the things I usually will ask our students very simply is, would you expect someone who works out every day, say running, like 2 or 3 miles a day, does moderate weightlifting, to have a greater density of bone tissue versus someone who basically sits on the couch all day, does work in front of a computer, and does no exercise whatsoever? A lot of times when we do any kind of exercise, our body will start to lay down more tissue to meet demand. And we'll talk about that kind of law in just a little bit. So very simply, when you take away gravity from an astronaut, what kind of things would you expect? The first thing we look at for bone tissue in particular is we start seeing what's known as known as spaceflight osteopenia. Osteopenia is the weakening of the bone tissue where there's loss of calcium. In this case, because there's no gravity, the osteoblasts have no indication to lay down more bone, but instead the osteoclasts keep doing what they're designed to do and keep breaking down bone. So you have osteoclastic activity outpacing osteoblastic activity without any real gravitational force to be put on the bone. So how do some of these astronauts counteract that? They do some form of exercise while in space. Now, other challenges that an astronaut has in space, and I mention this only because this is very interesting to me as far as anatomy and physiology goes. The other things that they also noticed was, obviously, if there's not enough gravity to work on the bone, there's also not enough gravity to work on the muscles either. So they are constantly doing both weight training exercises and cardiovascular exercises to make sure there's enough stress on the bone so they don't atrophy the bone and the muscles in conjunction with one another. They also notice there's going to be the fluid distribution because there's no down on the International Space Station. There's no gravity to pull any kind of fluids down to the feet, that they'll have a lot of edema, especially in the extremities in particular, unless they do, again, any type of exercise in particular, allowing the muscles to move to kind of pump blood through the venous system. They also notice they have fluid distraction in the eyes, where very simply it starts to expand, so that can distort their vision at the same time. And finally, they also have problems with vestibular challenges, which means they may develop problems with orienting themselves in space. They may have vertigo. They may also get headaches because they may have increased fluid retention up in the head, almost like the fluid is actually squeezing the head, so to speak. So some of them do experience some types of headaches. So this is all under the absence of any kind of gravity. Once they return to Earth, it's almost like a very quick, sudden change. Now all of a sudden you've got different body parts that are not used to having the gravity, so the person may feel very weak. The bones may have extra stress being put upon them that haven't been on there. for a number of months, like Mr. Kelly had done. The muscles may be very weak as they kind of reaccustom themselves back to Earth's gravity. So they are usually into quite a bit of a painful undertaking coming back down to Earth. The other thing I didn't mention too is when they're also in space, the joints tend to elongate as well. And once you have that, you start getting synovial fluid starts to build up within those joints too, and then they swell. You can imagine you get back down to Earth, and gravity fully sets in, and you're basically squeezing all those joints with all the body pressure, the weight of the body, plus all the extra synovial fluid, cause horrible pain in the joints there as well. Fortunately for Mr. Kelly, Scott Kelly, he actually was able to return back to normal levels by, I think, by around 6 months, being back down on Earth. Some other things that they noted too, which some of you may be aware of with the DNA, is telomeres actually allowed the DNA to lengthen, so you're able to repair itself a little more easily. We'll talk about that a little more so we get into some of the physiological changes of the neurons as well. We'll be talking into one of the later chapters. Other challenges that he faced as well, he did have headaches when he came back in. It did take him a long time to get back both his cardiovascular output as well as any kind of muscular output as far as strength training goes. It did take him quite a while to build himself back up. So when you answer this question, I want you to take into account some of the things that I had talked about here, but also throw in what you also think the person may undergo in space. They have done studies on different types of animals. They've looked at jellyfish, they've looked at rats, they've looked at a couple other invertebrates while in space, and a lot of them had a lot of difficulty trying to reorient themselves once they came back down to Earth. They noticed loss of muscle mass in the rats, but then eventually once they were back acclimated to Earth, they're able to reorient themselves back to Earth's gravity and somewhat function somewhat normally. So I encourage you to look and kind of delve in a little bit. Even if it's theoretical, there's no wrong answer. Just see what else you think may actually pose a challenge for an astronaut, both while they're in space and also when they come back down to Earth, at least as far as bone tissue goes. And if you want to extrapolate into the muscles and joints, then please do so. Now, a nice little follow-up question to the question regarding the astronauts in space is what happened to a baby if a person was conceived, born, and raised in space under zero gravity? How would you describe any kind of difference, if any, to either the bone tissue compared to a person who may be conceived, born, and raised on Earth? Now, as we know, there hasn't been any human birth in space as of yet. I know that's been in the workings with NASA for quite a number of years. They have had other animals born in space, including fish, jellyfish, and also, as I mentioned before, rats as well. So what would you expect to find as far as a change in the bone or osseous tissue? Would you expect it to be more bendy, more cartilage-like, and not quite ossified? Or would you expect it to be fully ossified as a normal birth would be here on Earth? One of the striking things is the baby in the womb is technically under zero gravity as well. They're almost somewhat weightless. So we notice in rats in particular is the osseous formation of the skeleton really has not changed very much in space. However, once the rat is actually born and then raised under zero gravity, we do see the reduction in bone density. We also see a reduction in muscle mass there as well. What we also notice too, they have a very difficult time trying to orient themselves in three-dimensional space and trying to figure out which way is up, which way is down. So you can imagine once the baby is born, and unless there's enough of gravity or gravity-like type of force being put upon the person, they could have some developmental issues. We do see some types of disease process here on Earth where there is a reduction in the actual bony tissue or ossification of cartilage, and some people have more of a cartilage skeleton, which we'll get into in a little bit. So from a developmental standpoint, at least from my perspective, with the lack of gravity, unless they can maintain a certain level of exercise, they're going to lose quite a bit of their bone mass, and also go a little further down the line, also lose the muscle mass, or at least not have as much muscle mass as a person who would be comparative living on Earth. And these people also might have elongated joints, may have elongated limbs. If they were to come back down to Earth's gravity, if they were fully formed past the age of 18 and 24, they may have some severe difficulties trying to acclimate to an Earth-like gravity. So again, This is just an open-ended question. You can go full theoretical if you want. There is no right or wrong answer. Tell me what you think. I know in some science fiction type of stories, they've definitely kind of extrapolated this on this quite a bit, especially those of you who watched the show The Expanse. From my mind, it's probably the closest it's ever come to what could possibly happen to people born in space. But it is something that I'd like you to each kind of like give your own perspective on. So we talked before about the most important slides in each chapter. This one, as well as the next one, is the most important slide in the entire bone tissue chapter. In this one, we see the basic units, basic functional units of bone itself. As I mentioned before, we looked at the formation of the compact bone. You have the formation of the osteons, also known as haversian canals. The osteon, very simply, is going to be the blood vessels along the osteonic canal. These are going to be surrounded by concentric lamellae of osteocytes found in lacunae, be connected through canaliculi from osteocyte to osteocyte. As I mentioned before, these osteons will run parallel to the diaphysis of the long bone. The next one you're going to see a little further in, go a little deeper into the bone itself. You find the osteons all throughout the compact bone. You find the trabeculae will form the spongy bone, the zero lattice network, which will also have osteocytes found in canaliculi with lacunae, but it's not going to be formed in an osteon type of format. It'll be more in a trabecular format in particular. So here we see a close-up of trabeculae. So you can see very simply osteocytes nestled within the lacunae. You see the lamellae of the concentric circles. You see the canaliculi of the adjoining osteocytes. And also you see at the osteoblast along the trabeculae of the new bone, next you see an osteoclast, which you see is fairly large compared to the osteocytes. So here we see it's actually breaking down the extracellular matrix, so breaking down the calcium salts and phosphorus salts to be released into the blood. We'll talk about what kind of factors will contribute to both either osteoblast or osteoclastic activity. We know gravity is one, hormones could be another, diet could be something else entirely. So this is a nice little animation that talks about bone growth and remodeling. Basically, it's a synopsis of what I just talked about here, but it does show a nice representation of what happens to the bone of someone who does a fair amount of exercise versus someone who doesn't. It's very clear to see how well the compact bone remodels itself due to proper stress versus not enough stress. Bone dynamics and tissue, we'll get into in particular the osteoclastic activity as well as different types of hormones that will influence both osteoblastic and osteoclastic activities. Now, we'll also talk about gravity as well as repetitive stress as well as exercise, so on and so forth. There's a law that we have that's not going to be included in your textbook, but I want to throw this in here in particular for those of you who may get into the medical field or nursing fields. This is taken right out of Guyton, which is a medical physiological book, which is the mainstay for most medical schools throughout the country for a number of years. I think it's up to, well, they revised it, I think it's Guyton and Hall now. They're up to the 13th or 14th edition. I myself had, I think, the 23rd edition, which was just Guyton himself. But Wolff's Law very simply states that bone in a healthy person will adapt to the loads under which it is placed. So very simply, if you load the bone correctly, it'll lay down more bone to basically strengthen that particular area under the load that is placed. So if load increases, the bone will remodel itself over time to become stronger and resort that sort of loading, or resist that sort of loading. So we see more osteoblastic activity. The trabeculae start to undergo adapt changes, and then secondary changes to the external cortical portion of the bone and becoming thicker as a result. Now the inverse is true as well. So very simply, if the load on the bone decreases, the bone will become less dense and weaker due to lack of stimulus required for continued remodeling. So again, the certain amount of gravity, the certain amount of weight being put on the bone will help build it up. The lack of any kind of external force will actually allow osteoclast to outpace osteoblast, and therefore will decrease the bone thickness, both in the cortical bone and also the spongy bone. There's a very similar law called Davis's law, which applies to soft tissue, which we'll get into in the muscle chapter and also into the joints. Very simply, and this is the mainstay of any kind of exercise, whether it be cardiovascular or whether it be any kind of anaerobic weight training, Davis's law says basically the same thing. So any kind of force that you put upon soft tissue, or if you increase the load, the muscle or the soft tissue part will remodel itself over time to become stronger to resist that sort of loading, as long as the force is done in a certain plane. So obviously, if you put a certain stress on, let's say, the bicep muscle in a standard bicep curl, it'll build the muscle up appropriately along the belly of the muscle. If you put force on it from a different direction, it may not build the muscle up very much at all. It actually may injure it at the same time. So Wolff's law is for bone. Davis's law will be for all soft tissue. Now let's talk about fractures. Fracture very simply is a break in the bone. The fracture could be very simply what's known as a hairline fracture, where very simply it only goes through a portion of the periosteum and the compact bone, or maybe complete fracture, where it breaks all the way through the compact bone on one side, all throughout the medullary cavity through the other side of the compact bone, or possibly through the epiphysis, or possibly through the metaphysis as well. So we do see different types of fractures that may occur, but they all go through the same types of phases. You have the reactive phase, which is the early inflammatory phase. You find the reparative phase, which starts with a fibrocartilaginous callus first, then a bony callus will occur second. Finally, you have the bone remodeling phase, which is the last step, as the bony callus will be remodeled. But we usually see, especially on X-ray, even with bone remodeling, unless you're very young of age, the bony callus will leave some type of visual scar on an X-ray. So more often times than not, you can pick out where someone had a relatively new fracture over the last couple of years. It does take quite a bit of time for the body to fully remodel to upper areas, so you're not going to find any kind of bony callus on a minor fracture anyway over 5-10 years past the actual event itself. However, it's relatively fresh. The first couple of years, you can see what we call a radial opaqueness, or a more whitening around the area, especially around the cortical bone of the bony callus. So here we see the 4 stages for the fracture and repair of bone. First, you're going to the reactive phase. You're going to have what's called a fracture hematoma, where basically blood is going to flood in the area, it's going to scab it. Next, you have the reparative phase, where the cartilage will start to form first. So again, very similar to endochondral ossification. You're going to have a fibrocartilaginous callus formation. If you notice here, notice how it is extending past the periphery of the periosteum. Okay. So you're going to see spongy bones start to form in the trabeculae. You're going to find new blood vessels that will grow into the area. Eventually, that fibrocartilaginous callus will start to ossify and form a bony callus. If you notice there, you still have that little outcropping of the periosteum there. Once it's fully ossified, you have what's known as the bone remodeling phase. So this is where the osteoclasts start to carve down on the cortical bone, both at the periosteal and also the endosteum edges. So it starts to reform back into very close to where the original diaphysis was at before the injury occurred. So let's talk about different kinds of fractures. The first fracture we'll talk about is not listed here. It's known as a simple fracture. Very simply, the skin is not broken and the bones are not displaced. It's just simple fracture. These include your hairline fractures. These include complete fractures where the bone is not displaced at all. The other types we're going to see here, both from a diagram standpoint and also a full-blown X-ray as well. First, we have what's known as an open or a compound fracture. This one has to break through the surface of the skin. This can be highly dangerous because it does leave the bone open to infection. So this is a surgical repair. You have a comminuted fracture, which a lot of times you'll see this with impact injuries. If you unfortunately, with the wintertime coming up, people that slip on ice and fall, a lot of times a impact injury with the arm outstretched, or if they jump, let's say from a high surface onto a hard surface, like jumping on concrete, you can actually cause a comminuted fracture either in the femur, a lot of times in the tibia there too. But very simply, a comminuted fracture is an impact fracture. So basically, you're jamming the diaphysis into itself. Next, we have what's known as a green stick fracture. We see green sticks in the children and also the adolescents. Green stick gets the term very simply from, if you ever look at a relatively young sapling or a young branch, they tend to be green. If you try and snap it, it doesn't break entirely. In fact, it bends first, and then a portion may snap. So very simply, with adolescents and or young children, the bones may not be fully ossified, so still may be more cartilaginous. It may not be a complete break. It may actually twist a little bit there as well. So this is different than, say, a fully mature bone, or if you want to go back to the sapling analogy, a fully formed branch can snap pretty easily. Whereas a green stick fracture we only see in children and also adolescents. The impacted fracture is very similar to the comminuted fracture here. We see this again with outstretched arm injuries, slipping on ice, or other bad falls, where very simply the bone will impact, but a lot of times you may not have as many shards as the comminuted fracture as well. So that's the main difference between impacted and comminuted. Comminuted, a lot of times you'll see some splinters here and there as well, whereas impact is usually like a clean shear. Now, pot and Colles fractures are very specific for the bone itself. So a Potts fracture, if you look at the X-ray on the top right-hand corner here, this is a fracture of the distal end of the fibula. The fibula is one of your lower leg bones. So you have a distal head. That fracture is usually from what we call an eversion injury. Those of you who are spraining your ankles before, usually your ankle will roll in, you get a sprain, but if it rolls outward, usually from a bad fall or a misstep, you can actually fracture the distal end of the fibula. Fortunately, the fibula is not a weight-bearing bone, so you can walk with this. Depending on if the fibula head is displaced, you may actually need surgical intervention to kind of get it plated or screwed back in the proper position. Next one is a Colles fracture. Colles fracture is found on the distal end of the radius. You should find this usually from some kind of impact injury, where they'd be struck in the hand, or sometimes you may find this too, where people are in bar fights and punch a wall. Besides breaking the finger bones, you can also break the radius at the same time. So pot fracture, distal end of the fibula. Colles fracture is distal end of the radius is fractured. Now, as we talk about long bone fractures in particular, one of the things that people in my line of work, or people do physical therapy, or do any kind of athletic training, or even any kind of training found in the gym, or even massage therapy, we have to be mindful of previous injuries to patients in particular. Those who have had long bone fractures have a high propensity of having blood clots. And a lot of times this can be complicated from deep vein thrombosis. So think about a long bone's anatomy, and why would significant fracture pose a threat to blood clots? Well, very simply, if we look at a long bone's fracture, if the fracture goes through the medullary cavity, you can actually disrupt the blood flow through a number of different areas. And we'll look at the next slide and see what happened there. So deep vein thrombosis, a lot of times if you have a fracture, you can actually damage the vein's inner lining, or also you can also damage the endosteum found in the medullary cavity. Because there's low blood pressure in veins, they're more apt to clot. So once activity is restored from a fracture, we can actually dislodge the clot and form an embolus. And as you know, an embolus can very simply lodge itself in a very precarious area. It can lodge itself in the leg, it can lodge itself in the arm, cause blood clotting there. Even worse, it can end up in the brain or the heart and cause either stroke or heart attack. But we often see this in femur and tibia fractures. So two major long bones of the lower extremity, the femur and the tibia. That's why it's always important, especially for my line of work, to always ask whether someone has had any kind of previous injuries in the past, no matter how far back it may be. And usually it's going to be the obese and or the sedentary patients that are more at risk. Those that have any kind of cardiovascular issues. Let's say if they have a high propensity of clotting anyway, or have a very high specific gravity of blood, or even the elderly, we have to be very careful with this kind of thing. So even those of you who may have had fractures in the past, you always want to make sure that if you have a history of cardiovascular injury or any kind of cardiovascular disease, before you start doing any kind of exercise, it's always good to at least get checked out to make sure there's no blood clots anywhere, especially in the lower leg or elsewhere. So let's talk about calcium homeostasis. So the bones will store roughly 99% of the body's calcium, the 1% we found in the bone, in the muscles themselves. So the parathyroid gland will secrete what's known as parathyroid hormone, which will activate osteoclastic activity, causing when the calcium level will drop, they'll increase the bone resorption, excuse me, and calcium will be released. So it also will stimulate the production of calcitriol by the kidneys to increase calcium absorption into the intestines. So very simply, we see a negative feedback mechanism here. So we have a stimulus where we notice that the blood calcium levels are starting to drop. The parathyroid gland cells are the receptors. It'll detect the lower concentration of calcium. The parathyroid hormone gene will kick in. It will actually increase the release of parathyroid hormone. Osteoclast will basically increase the bone resorption, or basically carve away the bone. The kidneys will start to retain calcium in blood, and excrete phosphate in urine and produce more calcitriol to draw more more calcium in through the intestines. So increase the blood calcium level to a certain point, and then blood calcium levels return back to normal. Now, the minerals for bone growth, as we know, most of the predominant mineral will be calcium, followed by phosphorus. Magnesium is something that a lot of times we'll recommend to patients in particular. Roughly, if you take calcium supplements, you want to take almost a 4-to-1 ratio of calcium magnesium. You find most of these in most of your common drugstores, including Walgreens, CVS. Most of them are now calcium magnesium supplements to be taken as part of your steady diet. Fluoride, as we know, is obviously very important, especially for the teeth. And manganese, which you find in a lot of our green leafy vegetables, and also in some types of legumes. These help activate the enzymes involved in synthesis of the bone extracellular matrix. Now, one thing we didn't talk about too much about before, we talked briefly in the intramembranous ossification as well as in the hyaline cartilage. Collagen is a huge protein found in most of the cartilage matrix. It's very important for the formation of bone there as well. So different vitamins are very important to help maintain the collagen levels in particular. And we'll look at some disease processes where we see either a lack of collagen or a lack of certain vitamins that can cause different types of diseases. Vitamin A, very important for osteoblasts. Otherwise, if you have any kind of deficiency, it stunts bone growth. Toxic, of course, in high doses. Vitamin C is very important for the synthesis of collagen. Deficiency leads to decreased collagen production. And if you remember, collagen allows a framework, a little bit of a bendy type thing, not quite elastic, but allows a little bit of a bend, don't break type of scenario for the bones themselves. Vitamin D, as we know, in the active form, calcitriol, produced by the kidneys, helps build bone by increasing absorption of calcium from the GI tract. It can slow down bone growth or cause both osteopenia and osteoporosis, which we'll talk about in a little bit. Vitamins K and B12, very important synthesis of proteins. Deficiency can lead to abnormal protein production, and very simply can also contribute to decreased bone density, in this case, osteopenia and osteoporosis. As far as hormones go, there's quite a few that will stimulate bone growth and also bone resorption. Growth hormone is going to be secreted by the pituitary gland, the anterior lobe. It's very important for the growth of almost all body tissues, including bone. Next, you have the insulin-like growth factors secreted by the liver, the bones, and other tissues. Very important for bone growth and also for stimulating osteoblasts, and also increasing synthesis of proteins, in this case collagen, for building a new bone. Your thyroid hormones, again, also will be helping to stimulate osteoblasts. Insulin, very important for synthesis of bone proteins. The sex hormones, very simple, will help with the growth spurt for both men and women, usually completing by the age of 18 to 21, sometimes 24, depending on what text that you're looking at. But this contributes to both osteoblast and also osteoclastic activity to try and help form both the cortical and also the spongy bone. Parathyroid hormone, as we talked before, this is going to be secreted by the parathyroid glands. It's good for bone resorption by osteoclasts, so we're carving out the bone, trying to get recovered calcium levels of the blood, and also formation of active form vitamin D. Calcitonin will be secreted by the thyroid gland. This inhibits bone resorption by osteoclasts. So too much parathyroid hormone will be opposed by calcitonin to help bring those levels down and try and keep that negative homeostasis going on throughout the calcium in the blood. As we mentioned before, exercise, very important as a weight-bearing activity, helps stimulate osteoblasts, also help build thicker and stronger bones, and retard loss of bone mass that occurs as people age. And of course, as our level of sex hormones will diminish, especially in women, unfortunately women are more prone to osteopenia and osteoporosis than men. Very simply, the bone resorption osteoclasts can outpace bone deposition by osteoblasts, and we start seeing a decrease in the bony matrix and the bony mass. So you have an increased risk of osteopenia and osteoporosis. Now, as we grow, especially during the formative years, we start to notice a very rapid growth of bone and very little osteoclast activity except just to mold bones to a certain shape and size. As we're adults, the rates are roughly about the same. As we start to age, especially in women, especially postmenopausal women, you start to see an increase in bone resorption and they'll outpace bone deposition. So looking at two slides here of scanning electron microscope of normal bone on the left, osteoporotic bone on the right, you can see very simply there's almost holes almost eaten away in the bone on the osteoporotic area. through there. This very simply is the osteoclasts breaking down more bone than the osteoblast can build it. Now, fortunately for most people that suffer from either osteopenia or osteoporosis, you can offset this through exercise and through diet, although sometimes you may need more of a stronger dose of certain types of calcium or possibly injections of different types of vitamins as well, help kind of build the bone back up. Now, unfortunately, X-ray is not a great way to diagnose osteoporosis. We generally use what's known as a DEXA scan, which is dual energy X-ray absorptiometry, which is very sensitive for any kind of bone loss. Usually what happens is we use a standard based on a 30-year-old woman and her spine and her bone mass. So we very simply come up with what's called a T-score. So a T-score from 0 to -1 will put you in the normal range. From -1 to -2.5 puts you in osteopenia range, which is the first step before you get to osteoporosis. Osteoporosis has to be at a T-score of -2.5. So that's standard deviations away from the norm of a 30-year-old woman. Osteopenia, if caught very early, again, you can catch this pretty easily and actually be able to build bone relatively easily. If you're more in the osteoporotic realm, unfortunately, what they are most looking at are going to be the hip bones as well as the lumbar spine, because you can get fractures in both of those areas, which are very difficult to repair outside of any kind of surgical replacement for the hip. And sometimes now they'll actually put in a cage to replace the lumbar vertebra. But any kind of compression fractures or stress fractures there can be very debilitating for the patient. Now, other bone tissue abnormalities besides osteopenia and osteoporosis, whereas osteopenia will be reduced bone mass, decreased synthesis of bone, the T-score will be from -1 to -2.5. So again, standard deviation from the 30-year-old woman. Osteoporosis is any T-score greater than 2.5, where the breakdown outpaces bone formation and you have full calcium loss. Again, we worry mostly about the hips and also worry about the lumbar spine due to the high incidence of fracture, where very simply it'll be a fracture and oftentimes the person will fall because of the fracture. Another type of bone tissue abnormality, we'll look at a couple x-rays of this here, is otherwise known as osteogenesis imperfecta, also known as brittle bone disease. Very simple, there's not enough or insufficient levels of collagen. Collagen is there to kind of help a little bit of bend and twisting motions to the bone. Without the collagen matrix there, very simply you have just calcium and phosphate salts. It fractures very easily. Osteogenesis imperfecta was actually pushed to the forefront just recently. If you guys have ever watched the movie Unbreakable with Samuel L. Jackson and Bruce Willis, Samuel L. Jackson played the villain with brittle bone disease, where very simply even just walking down the street and just twisting the ankle could be sufficient for breaking a bone. Most people with brittle bone disease are in constant pain because of the fractured bones. You could also have what's known as Paget's disease, where very simply we had talked about before about osteoblastic versus osteoclastic activity. When osteoblastic activity starts going into overdrive and it's not matched by osteoclastic activity, you have what's known as cortical bone thickening, which is exactly what you think it is. The cortical bone gets very thick. You have people that have very prominent features, especially around the head. They have prominent cheekbones, prominent eyebrows. They have a prominent EOP, which we'll look at in just a little bit here too. Another one I want to point out is there's rickets and osteomalacia. Rickets is a child-borne disease. Osteomalacia is the adult equivalent, where very simply you have a vitamin D deficiency, which means there's not enough calcium. So you have rubbery bones because there's more collagen than there is any kind of calcium or phosphorus. So there isn't full ossification there. So again, they tend to be very rubbery bones. They tend to be bow-legged for the most part. So osteoporosis factors, again, most women are going to be over 50. Very few men will get this. It's usually about a 4-to-1 ratio of women to men. Usually the contributing factors include reduced estrogen levels from ages 60 and up. In men, usually what ends up happening is the bone resorption outpaces the formation, usually due to poor diet or not enough diet of dietary calcium. So traditionally, this goes for men and women. They'll get estrogen therapy, calcium, vitamin D. They'll take in magnesium again, and also usually a 4-to-1 ratio of calcium to magnesium. And definitely weighted exercise, but it's a slow process. You have to build yourself up because too much too quickly can also cause fractures in the affected bones there as well. So here we see an example of osteopenia and osteoporosis, and you can't diagnose osteopenia or osteoporosis off an X-ray, which is what these are. but very simply you see roughly the same kind of bone deterioration on these particular x-rays. So if you go back a couple slides and look at some of the x-rays that I've shown, most of the bone will have a very thick cortical bone, whereas very white, we call it very radio-opaque. As you notice here, it's somewhat of a very thinned out cortical bone on both the left and also the right. The right more so at the hip joint themselves, as well as the femur head and the femur and the femoral neck. These are both so significant bone loss. It could be anywhere from 30 to 50% bone loss already just from the x-ray. The DEX scan will give us a better idea of how much bone loss there is in this particular specimen. But again, you can see very little cortical bone on both the left and right femur heads. The rest of the bone, especially in the pelvic area, including the sacrum and the ilia and the pubis and the ischium, look relatively thin there as well. You can see an abundance of the soft tissue. You kind of guess this person might be overweight, if not obese. So it's certainly it's not helping very much this particular problem. Here we see rickets and osteomalacia. You see the same basic clinical features here. You see that the bones are bending very easily. You see that there's no ossification from the epiphyses to the actual diaphysis. The one on the left here is a child. The one right here is an adult. Adults with osteomalacia do not tend to grow to be very tall because very simply the bone, again, cannot bear the weight, so they tend to actually have a collapsed vertebra there as well. But the long bones do tend to bend quite a bit in both rickets and osteomalacia. So again, this is usually due to either a lack of calcium or the lack of ability to absorb calcium and actually deposit it onto the bone. So you have primarily, mostly collagen and cartilage in the bones themselves and allows them to bend. This is Paget's disease on the right. On the left, this is known as a lateral skull. You see very nice, clear dilation of the cortical bones, especially around the skull bones themselves, the frontal parietal, as well as the occipital. You can see what's known as a cotton wool appearance. So very simply, the osteoblasts are going haywire at this point. So you can see they have a very elongated jaw, a very prominent forehead, forming very prominent brow ridges, and the EOP, the external occipital protuberance, you see it's almost like a hook just behind the vertebra and the posterior portion and the inferior portion of the skull. So as you can imagine, this person's head is very heavy. For the most part, these patients tend to have very thick muscles because obviously they're responding to the weight of the head in particular, and also the weight of the facial bones as well. And last, we have osteogenesis imperfecta. This is where the collagen is either lacking or simply missing from the actual bones, so they tend to be very malformed and will fracture very easily. These are very simply pictures of children with brittle bone disease. Unfortunately, it's a very high rate of fatality with people with osteogenesis imperfecta. As you can imagine, any kind of even a brief hug could possibly fracture the bones. It could be any bone. It could be the long bones in the leg or the arms, it could be the rib cage, or possibly even the vertebra. But these people, unfortunately, are usually in quite a bit of pain throughout most of their life.